Hi, I am presenting to you my presentation on eating disorders. My case formulation. Alice is a 10-year-old female uh, presenting today with her mother after a referral from her PCP, primary care physician, with concerns for anxiety interfering with her appetite that has resulted in a decrease in her weight at the fifth percentile on the growth chart. She has resorted to eating small meals, small portions over longer periods of time. Parents have tried to allow her to choose foods that are appealing to her, eating at different restaurants, different cultured foods, with no improvement. Alice is noted to have been born at 34 weeks, just placing her at risk for developmental and growth delays, although normal development was reported by the age of 2. Research has identified an increased risk of long-term negative outcomes such as developmental delays, chronic diseases, as well as mental health disorders such as anxiety and depression, according to Monaroli et al. Alice continues to have a small stature, but this is the first time that she has been below the 25th percentile for growth. She is an only child of 2 professional parents that divorced when she was 5. She has stopped socializing with peers and isolates at home most of the time. Previously, she was reported as being social, talented, and admired by her teachers. Recently, she reported being scared to eat in public, emphasizing that her stomach feels better when she's at home. She often goes a full day without eating anything, and she reports that her fear of vomiting started at the age of 4 after an episode of vomiting when she ate. My first differential diagnosis is avoidant restrictive food intake disorder. This individual meets all the criteria for avoidant restrictive food intake disorder, except for the fact that she is not dependent on nutritional supplements or enteral feedings. Alice has stopped growing and at the fifth percentile for growth. She has not gained any weight over the past year, and this may signify a nutritional deficiency. And these symptoms have interfered with her psychosocial functioning, evident by her lack of socializing at school. The eating disorder does not occur in the setting of anorexia or other disorders, not related to any other medical conditions, and cannot be explained by a lack of food resources. My differential number 2 is other specific food feeding or eating disorder. This diagnosis is applied when the individual meets all of the criteria of a disorder, but not full criteria. Alice does not meet the full criteria for anorexia, as she reported that she has no concerns for her body image. Continued assessment is needed to see if other symptoms in her life suggest that she does suffer from body image disturbances. The French diagnosis 3, social anxiety. Alice reports a fear of vomiting after an incident that happened at the age of 4. She has since developed a fear of eating in public places where others can see her. She also reported that there's an unsettling feeling she gets in her stomach that is better when she's at home. The APA reports one of the criterions includes the anxiety or fear of being scrutinized by others. The anxiety is reduced by avoidance, has occurred for longer than 6 months, and symptoms not caused by a medical substance or medication or another mental health disorder. So my primary diagnosis for Miss Alice is avoidant restrictive food intake disorder. This diagnosis is appropriate for Alice as she is currently struggling with food avoidance with inadequate intake and has no interest in eating. These symptoms most likely started early in childhood, but she did not have any weight loss or stunting of growth to be considered a significant concern. She currently meets the criteria for this diagnosis, and she displays an eating disturbance with the failure to achieve weight gain, with a psychosocial functioning interference and nutritional deficit at the fifth percentile in the growth chart. Pharmacological treatment. Her parents and herself will be informed there are no Food and Drug Administration approved medication to treat ARFID. Medication is considered a supportive treatment for other disorders that may be associating concerns that are present, which are also helpful when addressing the treatment of ARFID. Off-label medication used to support weight and appetite concerns will be mentioned, but not recommended, as treating the underlying cause of this disorder is first and best. Non-pharmacological treatments and lifestyle modification. Cognitive behavior therapy, or ARFID, is the standard of care for children and adolescents, with a focus on addressing the fears related to eating, restoring health, expanding the variety of food eaten, and addressing other health issues such as mental health. Cognitive behavior therapy is the standard of care. Alice appears to be suffering from anxiety, and CBT will also address the anxiety related to food and help develop coping skills to manage this anxiety. This treatment incorporates a combination of family-supported or individual treatment model, helping the individual and family understand how ARFID developed, and helps to develop individualized tools to address their needs and improve outcomes. I would help her mother understand that creating a positive mealtime environment is important, and working together with her at her own pace, as there will eventually be introduction of new foods. Alice's mother will be encouraged to develop a routine at mealtime that is free from distraction, incorporates family bonding, encouraging eating at her own pace without judgment, and making it a time that she looks forward to. They will also be encouraged to plan meals together, including some of Alice's favorite foods, suggestions, and cooking together occasionally. I would also suggest a healthy snack that Alice can eat at school, getting permission to eat in the nurse office to feel safe with less distractions. The use of a food diary would be helpful to track progress and bring therapy to evaluate and get feedback. And it suggested that treatment plans be tailored to the individual's specific needs to allow identification of things that precipitate the behavior. During the visit, a short meal plan and schedule will be developed with Alice's input to include food she may eat with the caloric intake that she needs to bring her and restore her nutritional health. A multidisciplinary approach to care will help improve outcomes for individuals with ARFID. The school, including the nursing council, will be included in the treatment plan for support, additional suggestions, and input about her treatment plan. The pediatrician, gastroenterologist, and nutritionist will be included to help rule out medical concerns, help identify nutritional deficit, and make suggestions to include in the treatment plan. Thank you for listening. Here are my references.